What I'm going to do is to show you some examples, live case example of using side guard. And I think some of the questions that were asked, hopefully we'll be able to answer, because all the issues about whether you cross, whether they're not stand into, whether you just treat the side branch, I've got examples of those that I'm going to show you now. So I've chosen 4 cases, and each case hopefully will give you some flavor of some of the important features of the side guard capillary stent. The first case I'm going to show you illustrates a good example of a case where a conventional technology is not suitable in terms of culotte or crush technique. Here is a 47-year-old lady with non-ST elevation infarct. You'll see there is a bifurcation lesion involving a diagonal which is almost perpendicular to the LAD lesion. And there's also a mismatch between the size of the diagonal and LAD vessel. Now in this case, provisional stenting is not suitable because you're very much highly likely to lose the side branch, and getting back into that side branch would not be easy. Crush is also not very suitable for the same reason. If you crush the diagonal, getting back to the diagonal in this anatomy and doing a kiss balloon is also going to be difficult. Culotte is also difficult because there is a mismatch, and diagonal is obviously much smaller than the LAD. So in this case, I elected to use the capillary side guard stent. In the first slide, you see the positioning of the side guard with the big dot just at the interface between the LAD and diagonal. And it's crucial to use 2 or sometimes 3 views to make sure that you got this point right. And this is probably the most crucial part of the procedure, getting the alignment and the positioning of the side guard absolutely spot on. Once you do that, you could see the capillary side guard is blown up here. I should say that the balloon is only 2 millimeter balloon in terms of, so it would just there to break the sheath so that the drug can be, the stent can be expanded. Once the stent is expanded, I'll put the main vessel stent. The main vessel stent was 4 millimeter stent. And whereas obviously the capillary here is about 3.2. Once the main vessel stent was placed, I did a kiss balloon, and this was the final result. Now the patient came back 2 months later because we needed to do a stage procedure to our RCA. So we had an opportunity to have a look at the LAD lesion 2 months later. And if anything, you could see that the bifurcation looks even better than when I left it, both in the 2 projection. So again, this is a case where other technology or other conventional techniques would not have been suitable, and side guard made it much, much easier. Second case is to illustrate the importance of having a technique whereby you always maintain access to your main branch, and you never have to lose your main branch wire. This is a 72-year-old patient with ACS and ongoing chest pain. As you can see, there is an extremely tight bifurcation lesion in the circumflex OM territory. So the lesion was predilated, and you see the lesion after predilatation. There is further lesion distal. In my mind, there was an issue of having to use a distal stent as well. Here you see the capillary, the side guard being positioned. Once again, making sure that the dot aligns itself at the border between the main vessel and the side branch. This is the picture after deploying the side guard stent. Now after this, we did an IVUS, and that caused extensive clot formation. At that time, we weren't sure whether it's just clot or whether it's dissection. So we lost the 2 branches. But you could see, if I did not have secured the diagonal vessel, and if the wire was not in the main vessel there, I would have had difficulty recrossing, and I would have had difficulty trying to reestablish flow as soon as you have to. Whereas with having the two wires, managed to use a thrombectomy device and immediately reestablish the flow. Following establishing the flow, I put a distal stent in the AV branch. And this is the answer to the question of whether you can pass a stent through the capella. And I've done that now in several cases without any difficulty and no problem with doing that whatsoever. So the stent is now placed into the AV sac. After that, this is what the result looks. Then I put the main vessel stent here, and then after that, I did the kissing balloon. Now, another point to make about the kissing balloon is that often when you have a main vessel stent, when you recross back to the side branch, use a small balloon to open the struts of the side branch to enable you to use a bigger balloon to do the kiss balloon. Now, in many circumstances, I did not have to do that. I could go straight with my kissing balloon, a 3mm balloon, through the struts and have good access to the side branch without having to open the struts with a smaller balloon. So that saves you one balloon and also extra step. And in this case, the two balloons went across with ease without having to use a smaller balloon in the first place. And this is the result after doing the kiss balloon. Now, the third case illustrates the importance or the property of the self-expansion that was alluded to by Dr. Colombo, and the fact that having the self-expansion can compensate to some extent if you have any intimal proliferation in terms of making sure that the luminal diameter still remains adequate. And also, this is a case where we're just thinking about treating the side branch, as one of the questions alluded to. So this is a 37-year-old man who was quite obese with non-ST elevation MI and hypercholesterolemia. So we did thrombectomy. Following thrombectomy, we did some predilatation, and after that, we positioned the capella, the side guard, just there. And you could see the result after deploying the side guard stent there. Now, after that, we carried out OCT. And you can see the OCT, the bottom one is actually through the stent. You can see the stent well expanded with a stent area of 5.47. This is an interesting picture because this is the OCT through the normal vessel, the adjacent vessel that was normal. And you can see the cap of the capella just sitting next to the main vessel. And the main vessel is not affected at all, remains healthy without any encroachment by the side branch stent. Now, this gentleman came back for stage procedures to his LAD about 6 weeks later. And there was some indication that there was some stent restenosis there. So we re-OCT the OM branch and the capella. So the first picture is the stent, the OCT we did first time when we actually deployed the side guard stent. This is the picture when the patient came back with the minor restenosis. As you can see, the stent has actually grown. The stent area was 5.47 initially. Now, after 6 weeks, it had grown to 6.56. There was quite a bit of intimal proliferation, around about 2.35. But because of the expansion, the luminar area still remained respectable at 4.21. So if we did not have this stent expansion, the luminar diameter, luminar area would have been 3.12, which is what is considered to be a flow limitation. Whereas because of the expansion, the area still remains not flow limiting, and therefore we did not have to do anything else here. Finally, again, showing a case to illustrate the importance of securing the side branch, as it was alluded to. This stent is not just for treating bifurcation, it's to making sure that you always have your side branch secured. And this is a good example of why this is important. Now, this is a case of a 75-year-old man with chronic angina. And he had very calcified lesions. And doesn't show it well, but the whole artery was very calcified. And you could see a tight lesion near the ostium of the diagonal. Now I decided to do rotablation. So we had rotablation through the diagonal vessel, following which this is the picture following rotablation. Then after that, we did further predilatation, and this is the picture. You can see already there is some dissection and some impression that there is dissection around this territory. So at this point, I wanted to make sure my side branch is secure. So I put the side guard in, and the side guard went in very easily. We didn't have any problem getting it done. And again, this is the picture positioning the side guard with the dot, and this is the position after deploying the side guard. Now, after that, trying to get the stent through here in the main vessel was not easy because of the, again, calcification. So what I did further predilatation. And as you can see, with the further predilatation, there was a dissection that actually extended beyond the side branch, behind the side guard, into the distal diagonal. So you would have imagined there would have been a potential of having lost this diagonal vessel if we hadn't had the side guard protecting it. And once you've lost the side branch, trying to get it back with the dissection would not have been easy. The other thing is that because I had the side guard there, I had the security of not having to worry about treating the side branch at this point. So I went ahead and treated the main vessel and put a stent in the main vessel. And this is the result after putting the main vessel. Now, you could see the projection is not very good, but in better pictures, there is actually quite extensive dissection beyond the capella distally. So I knew I had to put another stent through the capella to treat that bit. And the stent went in with no problem, easily through, and I managed to stent the dissected portion as well. And this was the final result. So really, these 4 cases illustrate all the properties that we have spoken about today, and shows you that how good this device can be in terms of safety of deployment and easy of deployment and getting good accurate results. Thank you.